Hello everyone. So now we will discuss pituitary and hypothalamic hormones. If we see pituitary gland, it is mainly divided into two lobes, anterior lobe and posterior lobe. So we'll start anterior lobe. It secretes several hormones like growth hormone, thyroid stimulating hormone, adrenal corticotrophic hormone, gonadotropins like LH and FSH, and prolactin. Whereas posterior pituitary secrete oxytocin and vasopressin. Vasopressin also called as antidiuretic hormone. So we'll start from the anterior pituitary hormones. So as we discussed, anterior pituitary secretes several hormones, but all these hormones are under the control of hypothalamus. Hypothalamus secretes some hormones which will increase or decrease the level of anterior pituitary hormones. Like for growth hormone, hypothalamus secretes two hormones, growth hormone releasing hormone and growth hormone inhibiting hormone. For TSH, hypothalamus secretes thyrotropin releasing hormone. For ACTH, corticotropin releasing hormone. For gonadotropin, gonadotropin releasing hormone. And for prolactin, prolactin inhibiting hormone. Now if you see carefully, hypothalamic hormones, they control the release of anterior pituitary hormones. Okay? So one question is asked, if there is a lesion between hypothalamus and pituitary, that means the connection between hypothalamus and pituitary is cut, what will happen to the level of anterior pituitary hormones? Okay? So if you see, hypothalamus, it is secreting the releasing hormone for every anterior pituitary hormone, but prolactin is only under the inhibitory control. So when there is a lesion between the two, hypothalamic hormones cannot reach the pituitary. So that means releasing hormone, when do not come, all these hormones will decrease. But for prolactin, inhibitory hormone do not come, so the level will increase. So if there is a lesion between hypothalamus and pituitary, all hormones of anterior pituitary will decrease, but prolactin will increase. Number one. Number two question asked, which hormone of anterior pituitary is under the inhibitory control of hypothalamus? Listen very carefully, which hormone of anterior pituitary is under the inhibitory control of hypothalamus? So that means hypothalamus secreting inhibitory hormones for which anterior pituitary hormone? Clear? So one obviously is prolactin, but second is growth hormone inhibiting hormone also. So hypothalamus secrete inhibitory hormones for two hormones of anterior pituitary, growth hormone and prolactin. But be very careful, if they ask the question which hormone of anterior pituitary is only under the inhibitory control, then answer will be prolactin, because growth hormone has both releasing and inhibitory hormones. Clear? Now in endocrine system, as such, there is nothing much to study in pharmacology, because mostly there are replacement uses. Like in physiology, we study deficiency of growth hormone is called dwarfism. In pharmacology, we study treatment of dwarfism is growth hormone, so replacement. Deficiency of thyroid hormone is called hypothyroidism. So the treatment of hypothyroidism is thyroid hormones. Okay? So mostly we have replacement uses. Okay? So here we will mainly discuss those hormones which have some other uses also apart from replacement. Okay? So in anterior pituitary hypothalamic system, such hormones which we will discuss are growth hormone inhibiting hormone, gonadotropin releasing hormone and prolactin inhibiting hormone. Mainly these three hormones. Okay? So we will discuss one by one, starting from growth hormone inhibiting hormone. What is the other name of growth hormone inhibiting hormone? Yes, it is called somatostatin. Growth hormone inhibiting hormone is called as somatostatin. Now special to remember, somatostatin is secreted not only by hypothalamus but also by many other parts of the body. So first of all, we will try to understand from where somatostatin is secreted, what is the normal physiological function and where we can use this. Okay? So somatostatin we just discussed, it is secreted by, yes, it is secreted by hypothalamus. What is the function? It decreases the release of growth hormone. So when it is decreasing the release of growth hormone, in which disease we can use? When growth hormone is high, the condition is acromegaly. So we can use somatostatin for treatment of acromegaly. Now apart from hypothalamus, where else somatostatin is secreted? Somatostatin is secreted by GIT also. In the GIT, somatostatin is secreted. What is the function of somatostatin? It is to decrease secretions. Somatostatin inhibit the release of substances like VIP, vasoactive intestinal peptide, or serotonin. So it decrease the secretions. So where we can utilize this? Obviously for secretory diarrhea. We can use it for secretory diarrhea, particularly due to conditions like VIPoma or due to carcinoid syndrome in which serotonin is high. We can use somatostatin. Then third place where somatostatin is normally secreted is by pancreas. Remember, pancreas has three types of cells: alpha, beta, delta. Alpha cells secrete glucagon, that will increase blood sugar. Beta cells secrete insulin, which will decrease blood sugar. And delta cells secrete somatostatin. So delta cells of pancreas, they secrete somatostatin, and the function of somatostatin in pancreas is to decrease insulin and glucagon. So in pancreas, the somatostatin function is to decrease the secretion of insulin and glucagon. So where we will use them? When insulin is high or glucagon is high due to tumors, insulinoma, glucagonoma. So we can say islet cell tumors, we can use somatostatin. Islet cell tumors, insulinoma, glucagonoma, somatostatin can be used. Now apart from these, somatostatin is a powerful vasoconstrictor. It is a powerful vasoconstrictor, and this vasoconstricting property of somatostatin we can use in esophageal varices. It's a strong vasoconstrictor we can use in esophageal varices, particularly when they are bleeding esophageal varices. Clear? So these are the important uses of somatostatin. If you want to remember them, you can remember from the name somatostatin. Somatostatin is used for somatostatin. These are S for secretory diarrhea, O for esophageal varices, M for malignancy of endocrine pancreas, or in simple language islet cell tumors, alpha cell tumor glucagonoma, beta cell tumor insulinoma, and A for acromegaly. These are uses of somatostatin, but somatostatin is not used for any of these. Why not used? Because it is very short acting. Somatostatin can be used but not effective commonly because of short action. So what we do, we instead of giving somatostatin, we use octreotide for all these indications. Octreotide is used for all these indications. Octreotide is nothing but long-acting somatostatin. Octreotide is long-acting somatostatin, and from the name itself you can remember its name end with the tide. Any drug ending with the tide is a peptide. It cannot be given orally, so octreotide is given subcutaneously. Remember, all the endogenous substance whose name end with in, endogenous not exogenous, in, name ending with in, like insulin, somatostatin, vasopressin, oxytocin, they are peptides, and the drugs which end with the tide are peptides, so they cannot be given orally. Okay, so these are the important points regarding the first hormone, that is somatostatin, or growth hormone inhibiting hormone. Okay, now moving to the second hormone, which is prolactin inhibiting hormone. Prolactin inhibiting hormone. Hypothalamus secrete this hormone, and this hormone is nothing but dopamine. So basically, hypothalamus secrete dopamine, which will stimulate the dopamine receptors in the anterior pituitary, and that will decrease prolactin. So basically, any drug which is a dopamine agonist, it can decrease prolactin. The drugs which are dopamine agonist, they can decrease prolactin. The examples of dopamine agonists are bromocriptine and cabergoline. Bromocriptine and cabergoline, they are dopamine agonists. And the uses of these drugs you can remember as dopamine agonists suppress plasma prolactin. Dopamine agonists suppress plasma prolactin. So one by one we will discuss. Dopamine, D for diabetes mellitus. Type 2 diabetes mellitus. Remember, only bromocriptine is approved for this function. We'll discuss in detail about dopamine agonist when we will discuss about diabetes. So bromocriptine is approved for type 2 diabetes mellitus. It improves insulin resistance. Okay. Then A for acromegaly. Acromegaly. Dopamine agonists, they can decrease prolactin but also growth hormone. So by decreasing growth hormone, they can be utilized in acromegaly. Which other drug we discussed in acromegaly earlier? Yes, octreotide. Octreotide can be used. This can be used. But third important thing is we have developed a new drug for acromegaly which is called as growth hormone receptor antagonist. Remember the other two drugs we just discussed, that means octreotide and cabergoline. Both of them, they act by decreasing the release of growth hormone. But this drug will block the receptor. It will not decrease the level, but it will decrease the function. And the drug which is growth hormone receptor antagonist is pegvisomant. Pegvisomant. So from the name you can remember its name and with soma ant. Soma stand for somatotropin. Somatotropin means growth hormone. Ant means antagonist. So it is a somatotropin antagonist, means growth hormone antagonist. Remember, do not confuse it with somatostatin antagonist. It is not somatostatin antagonist. It is somatotropin antagonist. So used in acromegaly. Then PEG, in the name it stands for polyethylene glycol. Polyethylene glycol, if added to a drug, it makes them long acting. So it is a long acting growth hormone receptor antagonist used in acromegaly. And this VI stands for the side effect. It causes visual problems. Visual problems are the main side effect of pegvisomant. Okay? So among the growth hormone antagonists, pegvisomant as well as the drug which inhibit the release octreotide, they are injectable. The only oral drug for acromegaly are cabergoline and bromocriptine. Remember, cabergoline is longer acting than bromocriptine. Okay. Then suppress means suppression of lactation. We know prolactin is a milk secreting hormone. So when there is lactation and we want to decrease that, so we can use cabergoline like drug. Like mother has given a birth to the baby, but after few days the baby dies. So milk is still secreting. So we want to suppress that. So we can use cabergoline. Okay. The next use is Parkinsonism. We know Parkinsonism is due to less functioning of dopamine receptors. So if we stimulate the dopamine receptors, we can treat Parkinsonism. So particularly the drugs like pramipexole, ropinirole, they are drug of choice for Parkinsonism. Bromocriptine can also be used in Parkinsonism. Then prolactin. So obviously they inhibit the release of prolactin. So used in hyperprolactinemia. Hyperprolactinemia. So these are the important uses of dopamine agonists. So basically prolactin inhibiting hormone. Okay. Then moving to the third group of drug, which is gonadotropin releasing hormone. So gonadotropin releasing hormone, as the name tells, it will lead to release of gonadotropins. That means it will increase LH and FSH. But gonadotropin releasing hormone is secreted in the body in a special manner, and that special manner is called as pulsatile manner. Pulsatile manner, the pulsatile name tells, it comes in pulses. So large amount of GnRH is secreted, then for a long period no secretion. Again large amount is secreted, again no secretion. So if we give from outside in same manner, that means pulsatile manner, it will do the same thing. That means increase gonadotropin. But if we give GnRH in continuous manner, or we can say non-pulsatile manner, if from outside we give continuously, non-pulsatile manner, then the receptors become desensitized. And if we give continuously, then it will start decreasing the gonadotropin instead of increasing. Okay? So if we give it continuously, it will increase gonadotropin. If we give it in pulsatile manner, increase gonadotropin. If we give continuously, decrease gonadotropin. Okay? So when gonadotropins increase, that will increase the sex hormones, estrogen, progesterone, testosterone. And if gonadotropin decrease, that will decrease sex hormones. So that means we can utilize GnRH for both the functions. Whenever we want to increase gonadotropin, we can use. Whenever we want to decrease gonadotropin, we can use. So what are the conditions where we want to increase gonadotropin? What are the conditions where we want to decrease gonadotropin? We'll discuss these one by one. In which condition we want to increase sex hormones? Like in case of anovulatory infertility. We know ovulation is required for fertilization. And which hormones trigger ovulation in the mid-cycle surge? Yes, it is LH surge. So when LH suddenly increase, that lead to ovulation. But if LH surge is not present, ovulation will not occur. And if ovulation do not occur, pregnancy cannot occur. So the condition called as anovulatory infertility. So GnRH, when we give in pulsatile manner, it will increase LH, induce ovulation that can treat infertility. Okay. Hypogonadism simply means less sex hormones. When sex hormones are less, we want to increase. But can we use GnRH for the treatment of less sex hormone, but there is testicular atrophy? Suppose a person is having testicular atrophy, testicles are not producing testosterone. So can GnRH treat? Obviously not. Because if end organ is damaged, then it will not be able to increase. So it will be used for that hypogonadism, which is due to less gonadotropic hormone. So that is known as hypogonadotropic hypogonadism. Not every hypogonadism, only hypogonadotropic hypogonadism. Clear? Then we can utilize in delayed puberty. We know puberty requires sex hormones. If sex hormones are not enough, puberty will be delayed. So we can utilize GnRH to increase the sex hormones in delayed puberty. Okay. Now, what are the conditions where we want to decrease the sex hormones? So we want to decrease the sex hormone most prominently in cancers, particularly prostate cancer. We want to decrease testosterone. So when we want to decrease testosterone, in which manner we will give? Yes, we will give in continuous manner, non-pulsatile manner. So cancers, particularly prostate, and sometime in breast cancer also we can utilize. We want to decrease the sex hormones. Then we can utilize in endometriosis. What is endometriosis? Endometriosis is ectopic endometrium. In simple language, if you say, normally endometrium is lining the uterus. But if same endometrium is present in ovary or somewhere else, it is called as endometriosis. The problem is, uterus normally has plenty of space. So endometrium normally respond to estrogen. So whenever estrogen comes, endometrium start growing. Uterus has plenty of space, it can grow without any problem. But when this endometrium is present at some other places like ovary, do not forget that it is endometrium. So whenever estrogen comes, it tries to grow. But space is not there. So it tries to grow, but space is not there. That cause all the problems. Okay? So if we decrease estrogen, it will not try to grow. So symptoms will stop. So we can use GnRH agonist in non-pulsatile manner or continuous manner to decrease the symptoms of endometriosis. Okay. Then opposite to delayed puberty, precocious puberty. In precocious puberty, we want to decrease sex hormone. So we can use GnRH in non-pulsatile manner or continuous manner. Clear? So simple language, wherever we want to increase, we can use. Wherever we want to decrease, we can use. Only the manner will be different. When we want to increase, we give pulsatile. When we want to decrease, we give continuous or non-pulsatile. Clear? Now coming to drugs. The drugs which we use, we say they are GnRH agonists. The first drug formed was leuprolide. But after that, many drugs have been formed, and we have kept the nomenclature that their name will end with relin, based on the endogenous GnRH, which is called as gonadorelin. So name should end with relin. The examples are nafarelin, gozerelin, buzurelin, histarelin. So any drug whose name end with relin, they will be GnRH agonists. Okay? The problem is GnRH agonists, these are not effective orally. They are not effective orally, so they need to be given by injection. Almost all are given by subcutaneous route, whereas nafarelin can be given by nasal route also. They are not effective orally, either injection or by nasal route in case of nafarelin. When we give them for increasing the sex hormones, we give pulsatile. When we want to give them for decreasing the sex hormone, we give continuous, non-pulsatile. Okay? Now, when we want to increase sex hormones, it is okay. But when we want to decrease sex hormones, what will happen? So when we want to decrease sex hormone, like in prostate cancer, what we will do? We will give them in continuous manner. Now the problem is, when we give GnRH agonist first time, body do not know whether we will give continuous or we will give pulsatile. So whenever GnRH is given, what will happen? It will increase gonadotropins, that will increase sex hormones, that will increase symptoms. So whenever we want to decrease the sex hormones, initially for 2-3 days there will be increase. So that will aggravate the symptoms, and that is known as flare up reaction. So that is the main problem. If we want to decrease the sex hormones, for first 2-3 days it will increase them. But when continuously GnRH is given, now the receptor become desensitized, and that will lead to decrease in GnRH, gonadotropins. So flare up reaction is the main problem, but after 2-3 days the symptom will start decreasing. Okay. So to avoid this problem of flare up reaction, we thought that when we want to decrease gonadotropins, then why to give agonist? So we developed a drug which is GnRH antagonist. GnRH antagonist. So as the name tells, they will block the receptor, and antagonist will always decrease. Whether we give pulsatile or we give continuous, they will always decrease gonadotropins. And the name of the antagonist will end with relics. Relics. The examples like cetrorelix, ganirelix, abarelix, dagarelix. Relics are antagonist. They will always decrease. So what will be the advantage over agonist? They will not cause flare up reaction. Advantage is flare up reaction is not there because they will always decrease. But what will be the disadvantage? The disadvantage is they are used only for decreasing the sex hormones. They cannot increase. So the left-sided users we discussed, like anovulatory infertility, hypogonadism, delayed puberty, we cannot use. They are only to decrease the sex hormones. They cannot be used to increase them. Second problem is they are also not effective orally. They are also given by subcutaneous route. That means agonist as well as antagonist, none of them can be given orally. Clear? But very recently, we have developed a drug called as elagolix. Elagolix is a new drug which is oral GnRH antagonist. Oral GnRH antagonist, and it is approved for pain due to endometriosis. Pain due to endometriosis we can treat by a new drug called as elagolix. Now if you want to remember the name, see carefully. GnRH agonist name end with relin, whereas antagonist it end with relix. So 4 letters are same, reli here, reli here. The only difference is it is ending with X. So X means cross, cross means antagonist. Clear? So X are antagonist, relix antagonist, relin agonist. Clear? And then if you see relix end with lix, so all the lix are GnRH antagonists. So we have elagolix, lix also antagonist. And the name says it is olix. Olix means oral antagonist, oral GnRH antagonist, and it is used for E means endometriosis, used for endometriosis. Clear? So these are the important points regarding the anterior pituitary hormones. Now we will move to posterior pituitary hormones. We know posterior pituitary secrete 2 major hormones, oxytocin and vasopressin. We'll discuss these one by one. Oxytocin. Remember, these are hypothalamic hormones only secreted through posterior pituitary. Oxytocin, it is milk ejecting hormone. Remember, prolactin is milk secretory. So it will secrete the milk. But outside the nipple, it comes through oxytocin. Right? Milk ejecting hormone. And second very important thing, it is oxytocic. Oxytocic means contract the uterus. It contracts the uterus. So the uses of oxytocin are based on these 2 functions. The use for milk ejection, it is used as a milk ejecting hormone. Like suppose lactation has occurred, but expression of milk is not there. Normally we advise to express the milk manually. But if manually we cannot express, then we can give oxytocin, it will eject the milk which has already been secreted in the breast. So it is used for treatment of breast engorgement. Breast engorgement. When the milk has been secreted in the breast but cannot be expressed, oxytocin is a drug of choice. Then it contracts the uterus, and contraction of uterus is required for, yes, augmentation of labor. It is used to augment labor, drug of choice. And second, for postpartum hemorrhage, it is drug of choice. We know we want to contract the uterus so that bleeding stops. So postpartum hemorrhage, augmentation of labor, breast engorgement, drug of choice is oxytocin. Okay. Then coming to vasopressin. Vasopressin, also called as ADH, it acts on two main receptors, V1 and V2. V1 receptor is present on the blood vessels, cause vasoconstriction, whereas V2 receptor has two major functions. One, it is present in the kidney, which result in decrease in urine. Second, it is, the name says ADH. Second, it also is present on endothelium and cause release of von Willebrand factor and factor 8. Release of factor 8 and von Willebrand factor from the endothelium. Yeah. So these are the basic uses. So if we see, vasopressin can be used to produce vasoconstriction, and vasoconstriction we want to produce in esophageal varices. Esophageal varices. So we want to stimulate V1 receptor, and the drug stimulating V1 receptor is terlipressin. So terlipressin is V1 agonist. It is drug of choice for esophageal varices. Okay. Second, it can decrease urine, and we want to decrease urine in nocturnal enuresis. Nocturnal enuresis, bedwetting in children. We want to stimulate V2 receptors. We want to stimulate V2 receptors in diabetes insipidus. Diabetes insipidus, which is due to deficiency of ADH. So neurogenic diabetes insipidus and nocturnal enuresis. The drug of choice is V2 agonist, and the drug which is V2 agonist is desmopressin. So desmopressin is V2 agonist. It is drug of choice for nocturnal enuresis and diabetes insipidus. We can also utilize when we want to increase von Willebrand factor or factor 8. So that means in case of von Willebrand disease and hemophilia, we can utilize desmopressin. Obviously, it is not the drug of choice. The factors will be treatment of choice, but we can utilize desmopressin for treatment of von Willebrand disease and hemophilia also. Clear? Now, if we talk about diabetes insipidus, it can be due to two reasons. One, ADH is not coming enough from the hypothalamus. Second, ADH is coming from the hypothalamus, but it is not working on kidney. If ADH is not coming enough from the hypothalamus, it is called as neurogenic diabetes insipidus or simply central diabetes insipidus. But if ADH is coming, but it is not able to work on kidney, it is called as nephrogenic diabetes insipidus or simply renal diabetes insipidus. So out of the two, in which condition will you expect that ADH will be effective, desmopressin will be effective? Obviously, when ADH is less. So we will replace, give from outside. So desmopressin is a drug of choice for neurogenic diabetes insipidus, but it is not effective in nephrogenic diabetes insipidus. We will discuss later on in the kidney that for nephrogenic diabetes insipidus, the drug of choice are thiazides. Thiazides are drug of choice for nephrogenic diabetes insipidus. Okay. The second group we can discuss are vasopressin antagonists. We just discussed vasopressin antagonists. If vasopressin via V1 receptor it cause vasoconstriction, and via V2 receptor it cause decrease in urine formation. So if we block the vasopressin receptors, then opposite will occur. That means instead of vasodilation, constriction, vasodilation will occur. Instead of decrease in urine, increase in urine will occur. So vasopressin antagonists, they can cause vasodilation and increase urine, and both of these are required in congestive heart failure. Number one, congestive heart failure can be treated. Second, both of these, they will be required in treatment of SIADH. If ADH is more, we want to reverse the action of ADH. So CHF and SIADH we can utilize, and the drugs which are vasopressin antagonists, their name end with Vaptans. vaptans. So vaptan, as the name tells, they are vaso, Va is vaso, P is pressin, and if we keep the T at the end, it become antagonist. Vasopressin antagonist. Clear? And the drugs are, we have tolvaptan and conivaptan. The major difference is tolvaptan can be given orally, whereas conivaptan is injectable IV. And from the name you can remember, if we talk in हरियाणवी, they commonly say इसको oral कोनी दे सकते, oral कोनी दे सकते, इंजेक्शन देना पड़ेगा. So conivaptan oral कोनी दे सकते, need to be given IV. Clear? So these are the vaptans. Now lastly, if we talk about SIADH, syndrome of inappropriate ADH secretion, means in this condition ADH secretion is inappropriate. But for that we need to know when the secretion is appropriate. What is the function of ADH first of all? To retain water or to retain sodium and water? Very good. The answer is to retain only water. So function of ADH is to retain only water. So when we want to retain only water? When there is plasma hyperosmolarity. So if the ADH is secreted when there is plasma hyperosmolarity, then this secretion is appropriate, normal. But if ADH is secreted when plasma is normal or hyposmolar, then it is not appropriate. Clear? So that means it will make more dilution, only water is retained. Clear? So syndrome of inappropriate ADH secretion is mainly characterized by hyponatremia, because water is retained when plasma osmolarity is normal or low. Clear? So in simple language we can say SIADH means excessive ADH. Clear? So hyponatremia is the main problem. So how to treat SIADH? First of all, the most important thing is fluid restriction. Person should not take more fluid because already there is dilution. Clear? Second thing, we need to give hypertonic saline. Normal saline is 0.9%, but here we want to increase sodium, so we have to give 3% sodium chloride, or we say hypertonic saline. And if these two measures do not work, then we will give vaptans. Vaptans, you can say, are drug of choice, among the drugs drug of choice, but they are used if these two things do not work. And lastly, we can use a damaclocycline also. Damaclocycline, it inhibits the release of ADH, that can be utilized. Clear? So this is the treatment of SIADH. Clear? So this is all about the pituitary hypothalamic hormones. Thank you.